So, all right, welcome everyone. Before we get started and I introduce our speaker, this is supposed to be a Christmas special medical forum. And so there is a prize here of grape juice that might have been fermented. For whoever can tell me at the end after Renee's spoken who these two are, prominent former University of Otago Medical School Leptospirosis researchers. And I hope this doesn't distract you too much during the coming 45 minutes. If no one gets it right, the prize goes to Renee. And I've told Renee already that New Zealanders are very polite, so everyone probably knows the answer, but they're not saying, so that she can have the wine. Anyway, I'll show you them again later on. So it's my pleasure to introduce Renee Galloway, who's a long-standing collaborator at the US Centers for Disease Control and Prevention. She earned a Bachelor of Science degree in medical technology from University of Minnesota and a Master's in Public Health from Emory University. She spent 5 years working as a bacteriologist with the state public health department in the US, and has since served in a number of roles in several laboratories at the US Centers for Disease Control and Prevention, including bioterrorism response, whole genome sequencing, identification of unknown bacteria that cause systemic infections in humans, and influenza. She currently holds the position of microbiologist in the Zoonoses and Select Agent Laboratory in the Special Pathogens branch at the CDC. And she's the US CDC subject matter expert for leptospirosis. She's also a commander in the US Public Health Service, although not wearing her uniform today. And she's received awards for work on bioterrorism, hurricane response, influenza response, surveillance, leptospirosis outbreak response, and for development of an identification scheme for Leptospira. As I mentioned earlier, she's been with her colleague Alec Hoffmaster, who just spoke over at Microbiology, have been very kind collaborators for a number of years on leptospirosis work in Tanzania, and have also hosted University of Otago PhD student Mike Mays, who's here at the CDC for leptospirosis work. So without further ado, I'll invite you, Renee, to speak to us on leptospirosis clinical diagnosis in humans.
Thank you, John. This is the first time I've worn a lapel mic, so hopefully you can all hear me. And I hope I don't end up dropping this, but I'm connected to a wire, so that's different. Thank you so much for having me. I really want to extend a huge thanks to John Crump and Mike Mays for graciously hosting and for bringing us here to Dunedin. It's been gorgeous and a wonderful visit, so excited to be here. I'm going to talk about leptospirosis clinical disease and diagnosis in humans. I did not put any clues in my talk about the identity of the scientists, so you probably all might fail the quiz at the end, but maybe not. There are no clues. Okay, so just a little bit of background about leptospirosis. It's the most widespread zoonosis in the world, and that is due to the very, very vast variety of mammal carriers that harbor it in their kidneys and shed it in their urine, so they contaminate the environment and spread it all over the world. There are so many different species of mammals that carry it, but the most common are cattle, dogs, and feral swine. And the rodent is actually the mammal that is most responsible for the most leptospirosis around the world. So in cattle, it causes abortions and low milk production. Dogs get clinical illness from it. And there are vaccines for dogs and cattle, but not a vaccine for humans. So leptospirosis is very common in areas that have seasonal flooding and heavy rains and poor sanitation. So most of these areas have rodent infestations, so the rodents maintain it in the environment and contaminate the floodwaters, and humans come into contact with the floodwaters. So not only is it associated with areas of poor sanitation in developing countries, but it's also found in developed countries and has been in more recent years associated with water sporting events such as rafting or canoeing. And these pictures are from an adventure race that took place in Florida in 2005, where they had an outbreak of leptospirosis among the athletes. And the race occurred in the Florida swamp waters that also had evidence of feral pigs rooting in the mud. And it followed Hurricane Wilma, which brought a lot of heavy rains and flooding there. So a little bit about the microbiology of Leptospira. It's a gram-negative spirochete. It's long and it's very, very thin. So it cannot be viewed with a gram stain. You have to view it using dark field microscopy, or there's a silver stain that you can use to view it. It also has characteristic hooked ends known as a shepherd's hook, and you can see it in the bottom picture below. It's also been called a question mark. And when they have very characteristic motility under the microscope, so they kind of spin on its axis super, super fast. So it's very characteristic to see these hooked ends and a rapid spinning. And they're divided into pathogenic, intermediate, and saprophytic species. So this just shows the three different groups of species. The saprophytes do not cause any human illness or animal illness, but they're found in the environment. Intermediately pathogenic species have been known to cause mild or limited illness, limited self-limiting fevers, but are normally not a concern. There have been 2 cases in the literature about 15 years ago maybe that found 2 intermediates that caused very severe leptospirosis, but those were the only 2 documented cases. And since then, we haven't seen any severe illness from intermediates. The pathogens cause human disease and animal disease. And L. interrogans is the species that's most widespread, and it's the most common species that is implicated in severe illness. So clinical presentation, the patients often present with very general, nonspecific symptoms. Headache, fever, rapid onset of fever, headache, and myalgias are the most common presentations. So it's very general and often is misdiagnosed as a viral infection. Most cases are mild, but in about 10% of humans, it causes severe illness with a fairly high mortality rate. Patients get very jaundiced and develop kidney dysfunction, which leads to kidney and liver failure. And this is known as the classical and is the most common presentation of severe leptospirosis. There are also some atypical presentations I wanted to brush on, and those are severe pulmonary hemorrhagic syndrome, meningitis, and chronic kidney disease. And I'll touch on those in a bit. But wanted to mention treatment for leptospirosis. So in the late stage of leptospirosis, antibiotic treatment doesn't seem to show much of an effect, probably because by that stage in the illness, it's very much an immune-mediated illness. So supportive therapies are required and much more effective than antibiotic treatment late in the severe phase. But research has shown that early antibiotic treatment can decrease the severity or the duration of illness. So early diagnosis is very important so that early treatment can begin, and hopefully that can prevent progression to severe illness. All right, so back to the atypical presentations. Leptospirosis was implicated as the cause of severe pulmonary hemorrhagic syndrome in 1995 in an outbreak in Nicaragua. It has an extremely high mortality rate and a very rapid decline in health for patients. And if you can see in the lung pictured on the right below, the lung tissue is almost liquefied because of the severe tissue injury caused by the organism. And it's been very commonly reported in Brazil, as well as parts of Asia. And we hadn't seen it in the US until about a year ago, when 2 workers at a vivarium that sold live birds and butchered them on site were diagnosed with leptospirosis with pulmonary symptoms. And unfortunately, one of them died from pulmonary complications. And a third patient was diagnosed with leptospirosis. He was not an employee of the vivarium, but lived about 2 miles from the vivarium in the same area of the Bronx, New York, where the previous 2 cases occurred. And it was known to be infested with rodents, so they were assumed to be the carriers of the illness. So leptospirosis has long been documented to be a cause of meningitis, but it's extremely underdiagnosed because it very often is classified as a viral infection. So the organism doesn't grow on conventional culture media, so often the patients are diagnosed with aseptic meningitis and don't receive proper treatment. We were involved in a case of chronic meningitis in a 12-year-old boy who went on a mission trip to Puerto Rico. And upon returning 3 months later, he presented to the ER with fever, headache, and uveitis. And he was sent home with treatment for the uveitis, but symptoms progressively got worse over time. He had repeated visits to the physician and was hospitalized 3 times. On his 3rd hospitalization, he had to be placed into a medically induced coma to deal with seizures, to try to control his seizures. And it was during that 3rd hospitalization that he was finally diagnosed with leptospirosis when they detected sequences of lepto in the spinal fluid. So they initiated antibiotic treatment and he was able to recover, and he was finally released from the hospital 76 days after that day of first admission of that 3rd hospital stay. And it was about a year after the appearance of the first symptoms. And lepto is also known to be associated with some other nervous system syndromes, such as Bell's palsy or Guillain-Barré, which have been commonly diagnosed after viral illness. So we saw a case of Bell's palsy in a 14-year-old boy whose dog was diagnosed with leptospirosis. And he had cared for the dog and also was diagnosed with lepto. And upon recovery, he developed Bell's palsy after his lepto infection. So previous literature have suggested that patients who recover from lepto recover fully and have no chronic complications. But we've lately been seeing a little bit more evidence of some chronic issues. I just talked about the chronic meningitis in the patient. And coming from a leptospirosis meeting in Palmerston North last week, we heard from a representative from the New Zealand meat workers who had been diagnosed with leptospirosis. And he said it took about 2 years to recover. Chronic kidney disease is also a very chronic, severe illness that has been seen in sugarcane workers in Nicaragua, as well as farm workers in Sri Lanka. And they are previously healthy young men who develop kidney failure, and there's no cure for it, so it's fatal. There's been no attributable cause 20 years later after the discovery of the syndrome. And it's been hypothesized that perhaps repeated exposure to lepto in these high stress environments where the workers are in very high temperatures and they become dehydrated, but that might be a contributing factor to this chronic kidney disease. There's a link, but probably a weak link, showing that there's a correlation of serological titers to leptospirosis and a marker of kidney damage. But more research certainly needs to be done to try to determine how much repeated exposures might contribute to any chronic problems. So because these clinical presentations and the syndromes are so different from each other, we try to use tools to help us aid in an accurate diagnosis. And we use clinical presentation, laboratory test results, and exposure history to try to make accurate diagnosis. So resource poor areas are the most common places that experience very large outbreaks of leptospirosis, and often they don't have a means to test for lepto. So a group from Sri Lanka has developed a diagnostic model scoring system to try to help in diagnosing. They picked mathematically 7 characteristics that contributed the most to an accurate diagnosis, and determined that a score of 14 gave a sensitivity of 80% and a specificity of 60%. And it may not seem great, but it may help in helping distinguish lepto from these other viral illnesses in these resource poor areas. And among the characteristics that they used, they found that exposure and risk factors was the most contributing factor to a correct diagnosis. So patient history is extremely important. Also, communication with the veterinary community is very important. Usually the human and the veterinary departments are very separate. However, if we're aware of any increases in cases in the animal community, we can be better prepared to recognize cases in humans. And also just to keep in mind the environmental cues, because it's well known and well documented that cases increase after flooding and heavy rains. Just a little bit about rapid detection tests. These are usually consist of a lateral flow format. They work very similar to a pregnancy test, where you look for the development of a line. So the one on the left, there's only one line, pink line. That's the control line for the cartridge. The second has 2 lines, and that means the patient is positive for IgM antibodies to lepto. So these are very inexpensive. They're easy to use. They're great field tests or for areas that have had no previous testing for lepto. They don't require any additional equipment or refrigeration. It can be done from a finger prick. So, and results are available within 15 minutes. But the sensitivity for these is usually low because they're antibody detection tests, and often the patient presents too acutely in order to detect that antibody. So depending on when the patient presents, they can be very low sensitivity in the acute phase. Some laboratory methods of diagnosis for lepto. Serology, which consists of this, like the rapid tests I mentioned, as well as ELISA. And microscopic agglutination test is the reference serological diagnostic assay. For molecular tests, it usually consists of PCR that detect DNA in the clinical specimens, and isolation of the culture, which is not done very, very frequently. As I mentioned before, it doesn't grow on conventional culture media, so specialized media is required. It also incubates at a lower temperature than other microbiological organisms, so usually a separate incubator is used. And they're very slow growing, so it takes 1 to 2 months to grow, so it's not appropriate for early diagnosis. So ELISA is usually a test that's run at the hospital level because they usually use ELISA for other infectious diseases, and it's easy to implement. So it detects IgM or IgG. These are very high throughput assays, so that's helpful in an outbreak situation where you have a large volume of samples. But it's still considered a screening test. It uses only 1 antigen to detect antibodies, even though there are over 250 known serovars of Leptospira. Which brings me to the MAT, or microscopic agglutination test. which again is the reference standard. However, it's extremely laborious and cumbersome. It consists of a panel of live antigens reacted against serial dilutions of patient sera. So we use a panel of 20 antigens, and they are live, so they have to be maintained weekly or biweekly. They've tried to do assays with killed antigen, but it doesn't work well. So we are need to maintain live antigens. The agglutination is read using dark field microscopy, and a fourfold rise in titer between acute and convalescent sera is considered diagnostic. However, even though we use a large panel of antigens, we can't predict the infecting serovar. So it was used to be believed that the highest titer was the infecting serovar, but research has shown that that is correct about less than half the time. So we really can't predict the infecting serovar. So our PCR assays usually target genes that are specific to Leptospira. Our assay only detects the pathogenic clade. And detection of DNA in a clinical specimen is confirmatory, although a negative won't tell you that they don't have it. And we experience pretty low bacterial load from clinical specimens. The organisms are only present in the bloodstream very transiently before they sequester into tissues. So the window of opportunity for positive PCR is very narrow. So in building on that small window of opportunity, if you look at the dark blue line, which represents the organisms in the bloodstream, it peaks very soon after the onset of fibromyalgia, but then decreases quite rapidly. And as the organisms leave the bloodstream and sequester into the kidneys, the light blue line represents the organisms being shed in the urine. And so that increases in the convalescent phase. And then the light tan line is the antibodies, which is very insensitive in the acute phase and increases as time goes on. So we like to do PCR on acute samples that are 4 to 7 days post-onset. And after a week of symptoms, we do serology and sometimes urine for PCR. But since the patients seem to shed intermittently, we don't like to do urine PCR singly by itself, but in association with serology. And we found that CSF is a very good specimen for PCR as long as the patient is symptomatic. So interpretation of lab tests. A positive rapid test or screening test is considered presumptive, so it needs confirmation. And the MAT is the confirmatory test, and a fourfold rise is considered diagnostic. However, there are problems with interpretation of this test. Often we rarely get paired samples that are drawn at the correct times in the illness. So we're often interpreting titers in a single specimen. And if the titers are low, or even if their titers are low in paired specimens and they don't show a rise in titer, it's difficult to interpret. Especially in endemic areas, IgG remains in the detectable in patients who have had a previous illness or exposure. So we can't distinguish between current illness and a past exposure using serology. We also have patients who never seroconvert. The 14-year-old boy who got lepto from caring for his dog was diagnosed with lepto using PCR, but he never seroconverted, even though the dog showed a very strong serological response. Also, if a course of antibiotics is started very early, it can really thwart the antibiotic response. So depending on when treatment was started, it could affect the patient's titer. Also, our antigen panel is limited. Usually patients cross-react with a number of different antigens, but there's certainly the possibility that we could be missing something from our panel. It's suggested that you use an antigen panel that's representative of isolates that are known to occur in your region, but we get a lot of people who travel to different countries and contract leptospirosis, so it's hard to have a ubiquitous antigen panel that will cover everything. And as I mentioned before, PCR, a positive is confirmatory, but a negative won't rule it out. So the best practice is to run multiple tests on multiple specimens, and that will result in the most accurate diagnosis of lepto, but it's usually not possible in a lab setting or clinical setting. So just to summarize, the clinical presentation is extremely varied, and I think the physician awareness that a bacterial illness could occur in an outbreak of dengue, for example, or instead of a viral illness, and that it has multiple different presentations is extremely important just to be aware. And that our testing is imperfect, and to interpret those tests knowing that while using multiple sources, including the clinical presentation, the lab values, and making sure a patient history is taken so that risk factors can be analyzed and aiding in the diagnosis. So that's all I have. I don't know if anyone has any questions. I'm happy to answer. Oh.
All right, I'm going to just set up this microphone.
We can throw you a microphone.
Yeah. Okay.
What are the chances of getting the infection? The reason I'm talking about is that we get it in South of India, a lot of pineapple plantations. Locals do get it seasonally, but they don't seem to care about it. Some of them die because but that's okay. Is there an immunity kind of thing to that?
Yeah, so it's thought that once you've had leptospirosis that you're immune, but as I mentioned, there are more than 250 serovars. So it often doesn't cross-protect. So you could get any other serovar, infected with any other serovar. So just because you've had it doesn't mean you're immune to other serovars.
You can be.
Yes, you can be. Yes.
So following on from that, how effective is the veterinary vaccine?
I'm not a vet, but I believe the vaccine is quite effective. But I think it has to be, at least in dogs, it's recommended annually, and it's not always given annually. For cattle, I think they vaccinate the herd and it does a good job, but I think then sometimes they get complacent because they haven't had any cases. So as long as they continue with the recommended vaccination schedule, I think it's quite effective. But again, the veterinary vaccines are also limited in their serovars. But cattle only are known to carry a certain number of serovars, and dogs. So the vaccines represent the most common ones in dogs or cattle. Yeah.
That means if I have high leptospirosis, can I contaminate the water?
You can if you're urinating in the water. Yes. Yes. Even we've actually even detected or isolated live organism from the urine of a patient who had fully recovered following antibiotic treatment. So there's a little window of time where patients are known to shed it in their urine. But there's very, very, very little human-to-human transmission. Usually it's dealing with animals. So we don't know. The same serovars cause that syndrome, as well as the classical kidney liver failure syndrome, which are completely different. So it's probably hypothesized that it's a number of different factors, whether it's bacterial virulence factors or host factors, but it's also probably related to the infectious dose that's inhaled in the lungs.
Are the different serovars, do you find them like located in different geographic areas, or is it like
Yes, so different geographies see different species. So there have been some species that are only found in the US, but they're much less pathogenic. The interrogans, the species I mentioned, is found worldwide on every continent and is the most common. But there are certain, species that are only found in certain areas. But the bad one, the worst one, is found all over.
Okay, well, there are no more questions. We'll just thank Renee again, and then I'll go to the quiz, because I know you were waiting for that too. Renee, thanks very much.
Thank you.
Okay, so any thoughts on these prominent former University of Otago Medical School leptospirosis researchers? I'll say that there were some very subtle clues in Renee's talk, but you'd have to be quite subtle indeed. Any takers? No, not Peter Snow. No, thanks for having a stab though. Anyone else? Mike, I know you know. That has I have a slide with the answers, but yeah, I can, yeah. Let me just, yeah, they both have a Leptospira species named after them, if that helps. Since Mike suggested, I'll just go back. There are quite a few Leptospira species, so I don't know how much of a clue this is. It might just trigger some memories. It's not the one with the red box around it. That was not Dr. Interrogans. No. It's looking like Renee might be getting a bottle of fermented grape juice. I don't know. Brendan's looking like he might be ready to come. You're going to stay out of it. Okay, fair enough. Okay, all right. The gentleman on the left is Leopold Kirschner. He was born in the Austrian-Hungarian Empire and fled the Germans to the Netherlands, where he trained at the Dutch Tropical Institute, and then moved to Indonesia, where he became the deputy director of the Pasteur Institute in Bandung in Java, and was proceeded to be interned by the Japanese there. He survived that experience and was recruited to University of Otago by Sir Charles Hercus right after the Second World War, where he led the microbiology research laboratory in the Hercus building on the 3rd floor. It's no longer a laboratory, but you can go and see it. When he came to New Zealand after the Second World War, New Zealand was thought to be free of leptospirosis, and he thought this can't be, and set about doing a series of studies that culminated in confirmation of the first human case in Auckland in 1949. Then it was also involved in confirming the first livestock outbreak that occurred in Westland near Hokitika on a dairy farm in 1951. The vet, incidentally, who worked on that outbreak is still alive, living in Palmerston North, and we had the pleasure of meeting him last week, Professor Neil Bruyere. He's 91. So Leptospira kirschneri is named for Leopold Kirschner. It's one of the pathogenic leptospires on the list. And then Emeritus Professor Solomon Fain did his medical degree here and then his MD in 1958 under Kirschner. Solomon Fain is still alive. He's also 91, living in Melbourne. And he has an intermediate leptospira named after him, Leptospira fainii. So just to say that there is a tradition of leptospirosis research here. You have to go back a wee way. But I hope that was of interest, and I'm sorry that no one got the wine, but Renee will be able to take it back to Atlanta. Thanks everyone for coming. Let's see.